What's up, everybody? Welcome back to the RT Clinic. Today I've got a cool video that is going to showcase a lot of respiratory devices. Now I've got 5 of them here. So I'm going to go through an explanation of what each one of these is used for. If you're teaching your patient how to do it, some quick notes on it. I'm going to link some videos up above while I'm doing this so that you can get a deeper explanation of some of these devices that you may see on your patient's bedside table. So you know what's next? Cut to the intro. So, I have 5 different devices here, and what we're going to look at, first of all, I'm going to sort them by what they do. So let's take them out of the package first, and then we will sort these devices. These are pretty common things you're going to see at your patient's bedside. So the first device you're going to see here is the Incentivespirometer. So this is going to be a device that's going to recruit alveoli, and so it's going to increase oxygenation. In some cases, they say it can prevent pneumonia. This is going to attach onto here, and so this is for lung recruitment. So let's put it over here. Whoa. Second device I'm going to show you is this one here. This is called an EasyPAP, also known as an AccuPAP in some cases. This is an Incentivespirometer on steroids. So let me explain a little bit about this. But it's going to look at something like this. It's going to hook up to a flow meter, and patient's going to blow in this side. I'll do a demonstration on that in a second. But that's going to also help to recruit alveoli and help with oxygenation. So let's put it over here with the spirometer. Next device. This is, and it has some funky stuff on it here. This is actually a handle. And so it flips out as a handle, has some colors on top of it. This is a respiratory device known as a peak flow meter. Has nothing to do with lung recruitment, has nothing to do with mobilization of secretions. All you're doing with this is monitoring airway resistance. In most cases, and in all cases, you're measuring your exacerbations of asthma. So how are your airways doing today if you have asthma? This is a monitoring tool. It has no therapeutic effect at all, but when used properly, it will be a tool to tell used as a guide to tell you where your flow rates are today and what medications you might need to assist. So, peak flow meter. This is a monitoring tool. So we'll put this dude way over here. Next one we have is this one here. This is a expiratory resistance device. So as you can see this here, and you see a spring in here, patient mouthpiece. Comes with a set of nose clips for your patient, so you're not going to lose air out of their nose when they're blowing into this. And what it is, expiratory resistance. So they're going to blow against some resistance. This is going to recruit alveoli. This will also help them mobilize secretions, and it's going to build muscles. It could also be called a respiratory muscle trainer, and it can be done by blowing into it or also sucking it and actually checking your inspiratory muscles. So I'll show you that in a little bit too. We're going to kind of put that over here more on the side of lung recruitment. And the last thing is, this is a VPEP from Dr. Burton, but actually it is also, generically termed Flutter Acapella, all those kind of different things. This is a vibratory device that when you blow into it, it's going to cause vibrations into your airway and move secretions around, try to get them into your large airways so that you can cough them up. So mobilization of secretions, this in combination with staying well hydrated and is really important. So this is for secretions. So we're going to put this guy up here. So we have recruitment of alveoli here with our IS, our EasyPAP, and our threshold PEP or intermittent muscle trainer. We also have over here is a simple monitoring tool, peak flow meter, nothing to do, no therapeutic value at all, except for it's a good monitoring tool for your asthma. So don't get those mixed up. This is something totally different. And then your acapella is to move secretions. You can also recruit alveoli by moving secretions, but it is mainly for moving secretions. So let's get in a quick demonstration of each one of these devices. So let's go to our Incentivespirometer first. If you want a really detailed explanation of Incentivespirometer, look up above. I'm going to put a link up above right now that you can click on and go into a long video about it. We're going to go into this quick though. The down and dirty of what you need to know. This is to prevent atelectasis is the best term for it. So the next device we're going to go to is going to reverse it, but this is actually going to prevent it. So what do you need to know about it? Well, it's got the piece for the patient on here. You have this area here, which is semi-important. And then this is the most important, the volume that we're looking for. How do I know what the volume is? Well, you really have to keep that piece of paper that comes with it, and it's going to tell you what their predicted volume is for being female and male and their height and age. So you're going to look at that with your patients, and then you're going to figure out what is exactly their target. When you get to their target, the thing is you're not going to be like telling them, you know, well, you need to do this and you need to do that. The best thing is just to keep it really simple. So you're just going to, I just go to the Incentivespirometer and mark what their target is. Your actual goal, we want them to get a third of their target. But if we have their target, and let's say it's 2,500, we're going to mark it, and that's where we want them to get the bell to. So most important thing about this is the breathing pattern. So with the patients, a lot of times if you hand it to a patient, they may blow into it. Well, that's wrong. This is all about taking air in, holding it, and releasing it slow. During that hold is where we're going to recruit alveoli, so it's really important. So if my goal is 2,500, the best way, and this is the down and dirty of it, the best way is to have them take a deep breath in, to hold it until the bell hits the bottom, then release it. 10 breaths per hour is really the best thing to do. So if they're doing 10 breaths per hour, it's really counteracting all of this atelectasis that's being caused, especially in this COVID pandemic type world where people are sitting in bed for a long period of time. And IS is really good because you're going to be aerating all those air sacs down there that could be collapsed because they're sitting in bed and whatever else they're doing, not getting up moving around. So taking a breath in, I have my target, exhale, now release. And you notice that I kind of pulled it out of the camera a little bit. I'll do it again. You're going to watch me hold the breath while the bell falls. And a slow release. And what we see is that when you recruit most alveoli when you do that breath hold. Just doing this, that's one thing, but holding it is where you're going to recruit alveoli. So that's the Incentivespirometer. It's kind of the basic thing, sits on the bedside table. That's what you need to know about it. What is their target? Make sure they're taking that breath in and hold it until the bell hits the bottom. It's really important. The next device is the EasyPAP device, and I'm going to have to run over to the flow meter to show you how this one works. The next device we're going to look at is the AccuPAP, and remember this is the IS on steroids. So this is not only going to prevent atelectasis, but this can actually reverse atelectasis. This is a small version of the old machines that used to be used years ago called IPPV, intermittent positive pressure ventilation, or breathing, sorry, intermittent positive pressure breathing, IPPB. Those machines aren't really around anymore, but this is what we have in the case to reverse atelectasis. So what it's going to do is actually going to convert the flow that's coming in from this side right here, and it's going to add a lot of extra flow coming to the patient, and then when they exhale, they're going to have expiratory resistance. And that expiratory resistance is going to be controlled by this guy right here. So we have 5, 10, 15, and 20. So on top of the airflow coming through to the patient, you also are going to have your expiratory resistance here. The manometer is really nice because that's going to show you what the current flow, actually pressure is, coming back to the patient. the combination of the resistance and this flow. So let me hook this thing up. I'm going to hook it up to 8 liters. I'm running off a tank. You usually run it off the wall, but run it on air. You can run it on oxygen. It's kind of loud, as you can hear. Make it a little quieter now by occluding it. But what's now 8 liters is going from here through here, coming out at the mouthpiece on this side. So let's start really easy. At 5 of expiratory resistance, we're going to watch our manometer. A couple real keys that when I do this device, if you're teaching your patients, you want them to keep tight cheeks. That's really important to forcing the air down to where it needs to go. Taking a lot of, having your cheeks loose really absorbs a lot of that pressure up in your upper airway, which does absolutely nothing for recruiting alveoli. You want to force it down. Tight cheeks to get that air down to where it needs to go. So that's really important. Let's hook it back up and I'll show you. So here we go. We're going to exhale into it. I'm going to take a breath in. You can see when I did that, you can also see the manometer come up just a little bit. There's not a whole lot of expiratory pressure. I didn't feel a lot with that. So I'm going to go up a little bit on my expiratory resistance. 15. Let's try this again. So not only do I have the expiratory resistance, I also have that air kind of forcing in when I go to take a breath in. So it's almost assisting my breath. That's where you're going to be reversing atelectasis. So our collapsed alveoli, that's where you're going to reverse it when they're taking that breath in. So I have a lot of focus. I tell my patients to focus a lot on taking that breath in and filling your lungs totally before you exhale. If you fill them totally and then you exhale against resistance, that's going to cause more back pressure, recruit more alveoli. It's really important. We say 10 times per hour with this. You can do it. I usually tell the patients to do it 3 or 4 times during commercials if they have TV on, which they all do. So because there's nothing really else to do. So I tell them 3 or 4 times, but I make sure if I leave it hooked up, it's kind of loud, which is kind of a bummer. So I show them if they're able to do this, and I've had some COVID patients specifically that have been like, what can I do to try to get out of here? They're on oxygen. They want to decrease their oxygen, so we're doing all kinds of different things with proning, with IS. I like throwing in this option because if the patient is motivated to do it, it will work. It really will, but you got to teach them correctly and put it on the right amount. I crank it up, put quite a bit of pressure on in those cases. This can also, you can put a nebulizer downstream of this, run flow in here, run the neb on this, and do a nebulizer on top of the expiratory resistance and the EasyPAP, or the reversal of atelectasis. Do them both at once. There's a lot of hoses coming in and flow meters, but it will work and it kills 2 birds with 1 stone. So let me crank it to 20. I'm going to go up on my flow over here. You can go up on it. It's just going to cause more resistance. So let's go up to 12. It's going to be a lot, and I'll do a couple of breaths with it. It's going to be quite loud now. Yeah, that's significant. So that will also loosen secretions, because anytime you're going to inflate airways, you're going to loosen secretions. So cool device, EasyPAP, AccuPAP, PAP therapy is what it's also called, positive airway pressure therapy. It's a really good tool that you'll see. It's got to have a gas source though, so that is one limitation that it has. Let's go to our muscle trainer. This is an inspiratory muscle trainer. This one's from Philips Respironics. It's not expiratory, as I said before. This is inspiratory only. Why in the heck would you want to train somebody's inspiratory muscles? Well, if you know it or not, and you've seen it if your patients are having trouble breathing, they're using every muscle they have. And these muscles can be weakened over time. So it's really important, especially somebody, you know, who is motivated to do the work to improve their muscles. Just like you were going to the gym and you were doing curls, your respiratory muscles are very important. Your intercostals, sternocleidomastoids, a lot of muscles in your chest that are really important, and you can work them with this device. Now I'm going to show you a little bit about it. It's got numbers on there, and what we can actually do is turn this aspect right here to increase. So right now at the red line we're about 27 centimeters of water pressure. So we can do that, and that is what the pressure is going to break off at when we take our breath in. So let's just start low. I'll start at 17, put the mouthpiece on. You're going to watch, I can blow through this all day long. There's nothing really going on with blowing through it. But when you inspire, it's going to pull a valve against you, and then it's going to let once you hit that pressure there, it's going to let air come in. So, and it stops there kind of at the end. So what I'm working on is my inspiratory muscles, which are those muscles that are really most important to be able to get the air in. So you're going to see. Now normal breath would be like this. Now I'm pulling through this, so it's actually working my muscles, giving me resistance. It's like sucking air through a straw. So when I do that, it is going to build up my intercostal muscles and other respiratory muscles. Now, if patients have neuromuscular disease, Guillain-Barré, something like that, they want to train some muscles or test their muscles, they can do that also. So let's crank it all the way to the top. Let's see if I can do 40. We know that if you're going to extubate a patient, you're looking for a NIF or negative inspiratory force. Greater than 20 is our goal, which is, when it comes to this, it's not a lot. And when it comes to the vent, it's not a lot. But let's try negative 40. Let's see if I can actually break it over. So I'm going to exhale, seal my lips, then take my breath in. Whoa, boy, that's hard to get in. So that is really hard to pull against. So if I do that 10 times per hour, that's really going to work on those muscles, and it's going to give them resistance so they can grow stronger. And that's really important, especially if somebody's been on a ventilator, mechanical ventilation, paralyzed for a while. This is a good device for that. It also, with that kind of quick air coming in and some changes to your airways, it could cause you to cough and release a little bit of secretion. But it is going to work for training your muscles. So I'm going to pull this thing out of the category I had it in. I had it in the category with the Incentivespirometer and the EasyPAP. This is its own beast. So this is a inspiratory muscle trainer. You don't see a lot of these, but if you do, look at it, it says IMT, and you'll know that's what this is for. So there's the IMT. Also comes with nose clips. So stylish. Still hard to do, even with nose clips on. So obviously your patients should have nose clips on so they're not going, ooh, that's not bad, I just pulled it through my nose. So anyway, there's something to think about, but there's inspiratory muscle trainer. Let's go next to our diagnostic kind of device that we're going to look at in monitoring asthma. That is the peak flow meter. Oh, the joys of the peak flow meter. So it comes with a massive handout. You can see a trending tool over here. This is like, I mean, overload. If you give that to a patient, how it is like reading something from a medication. So has a lot to it. What you really need, your patient needs, is somebody who specializes in asthma management to discuss this with them. Respiratory therapists usually can do that, but this is like, it needs, if you're going to really do peak flow meters correctly, it needs to be a half hour to an hour of teaching with the patient on how they're supposed to do it and then what they're looking for. If not, this means absolutely nothing. Although this is a great tool to give them that warning before they get in an exacerbation. So then they can change their meds, call their doctor, preventing exacerbations. And if you've ever had an exacerbation of asthma let's just start with asthma. COPD is another beast, but if you've had an exacerbation of a lung problem, panic sets in and you really tend to forget what you need to do first. So this is something that you can use to monitor, to start yourself on by changing medications or on recovery before you get to that point. So really need somebody that's specialized to talk to about this. before they go home with it. It's not one of those things, say, here's your peak flow meter, read the instructions, because I'll be honest, they probably won't make a ton of sense. But you have to use this a lot before you can figure out how it works. Let me give you the quick rundown on it. Peak flow, what peak flow is the fastest speed you can blow out. So you're going to see this right here on the monitor, and you're also going to see numbers going up this side. The little red one right there is going to measure your peak flow. So you see your numbers, your peak flow. These little guys, we're going to show those in a second. So what I need to do is you need to do this for at least probably a week to find your normal peak flow. So what you're going to do in the morning, you're going to do 3 and take your best. So peak flow, you got to blow fast, really fast. We're measuring speed. So it's going to look something like this. The handle is nice. You can have a mouthpiece on there. In this case, I'm not. And I'm going to blow. So when I blow, you can see, if this bad boy will focus on it, you can see I'm about 550. So 550 is where I am there. I can pull it back, do it again. I get about 650 that time. So I don't have I don't have asthma, and not any exacerbation right now. Do another one. So as fast as I can, open mouth, and that's about 600. Let's say 600 is where I am on a normal day. Well, that's really good to know, and that's how we set these things. So after you figure this out over a week and you get your normal values, then we set these different pieces, and you can see these little colors here, by what your zones are. Green, yellow, and red. Obviously, green's go, yellow's yield, and red is bad news zone. So we would put the green at 80% of their total, or we could actually put it at the top. So this is the way I would usually do it. I'd put it at their top is about green. 75% of that I would put yellow, and 50% of that, which would be, in my case 300, would be a bad day. So I would have them spread out, and there's a specific formula for this in the asthma education program. So what you're going to look for is the patient, if they're not feeling well, they're going to do a forced effort, and they're going to see what their peak flow comes up with. If their peak flow is in the yellow zone, so that's anywhere from yellow to red, they're going to be specific to taking maybe extra breathing treatments, maybe starting a steroid, something like that, calling their doctor. That's in the yellow zone. You like to be in the green zone. If you're in the yellow zone, that's not as good. If you're in the red zone, those are times where it's like you know that you're in an exacerbation. So these are times where you seek medical help. Now, the teaching for it is way more involved. It's all written out. Stoplights, so you got green, this is what you do. Yellow, this is what you do. Red, this is what you do. But this is a peak flow meter. It doesn't do anything as far as recruiting alveoli. It is only for monitoring your asthma. Peak flow meters, not for obstructive disorders. We don't use these for COPD. It's a different type of disease. Only used for asthma. You see a peak flow meter, asthma. Peak flow, asthma. Peak flow, asthma. It's not peak flow, all their lung problems. It's not that. This is for monitoring asthmatics. So, and the asthmatics out there are saying, yes, that is what it's for. And maybe you use it, maybe you don't. But I'll tell you, if you can prevent exacerbations and you can have a number to go with the fact that you feel like you're getting short of breath, you can have a number to go with that. It's really important when talking to your physician or provider and getting the next steps of treatment going forward. So, peak flow, there's a lot of teaching to it, but that is what it is all about. So, monitoring your asthma. And the last one is the Flutter Acapella. In this case, we call it a VPAP. There's all kinds of different ones. This is going to be a big breath in, exhalation, tight cheeks, forcing that air down and vibrating it. And this doesn't get secretions out. I'm going to tell you, it does not. Your forced cough after does. Okay, so you can't sit there like a slug or somebody like a slug. Seen it all the time. That does nothing, and you can see my cheeks actually moving. It's vibrating in my mouth. So people have to take an active role. Your patient have to take an active role in doing this, and every time it's done, every time you're done doing 10 breaths, you got to finish it with a directed cough of some kind. No, none of this clear throat, stuff like that. This, if you're going to use it, you might as well use it right, okay? We've seen it used wrong thousands of times. So the top part is a resistance piece. So this is going to change the resistance. So I'm going to go all the way up on the resistance. That one there. So I'm all the way up on the resistance, and I'm going to show you how to do a breath with this. You're going to see when I blow this breath, watch this stuff inside of it. See the vibration, air is going to come out of here, and you're going to see a vibratory device. It's going to cause vibrations back into your airways. So some keys to taking it: 5 good breaths is good, and a directed cough. So I'm going to do 2 breaths and show you how to do a directed cough. Big breath in, seal your cheeks, blow out, but when you feel like you're out, keep squeezing that last bit. That last bit of air really seems to what knocks stuff loose. Our goal is not to knock it loose so that it just evaporates. No, we're trying to knock it loose to get it in large airways so we cough it out. It doesn't just magically fly up and come out. If you have pneumonia, it just doesn't magically go away. You have to work at it, and you got to get your mucus out. This will help you. So we're going to take our breath in. Right there at the end. That was good. Let's say I do 8 more. Here's my 10th. So I'm done. Now I'm going to do a directed cough, and in this case I teach a lot of patients the 1, 2, 3 cough. That's the 1, take a breath in. 2, tighten your stomach muscles. 3 is forcefully cough out. So it's like this: 1, 2, 3. Forcefully cough out and get air behind it. You've got to get air behind it. Well, we can use these tools, EasyPAP, that kind of stuff. That's going to help get you more air behind your cough. So that's how that kind of stuff can recruit alveoli. You need to get air behind your cough. Doing this does nothing. You got to get air in, lungs full, tighten muscles, and force it out. That's how you're going to get things from your small airways to your large airways so that you can cough them out. So I do hope that this was a helpful little rundown of some respiratory devices. Make sure you comment, like the channel if you do like the stuff that you're seeing, and give me some suggestions. I'll do whatever I have equipment to do as far as videos, and excited about 2021 being just off the chain amazing. So I'm excited about all the things that are going on in medicine, and keep fighting, guys, and keep shining the light in the darkness. That's what y'all are doing. I'll see you.
You can stay.